It's a pleasure to introduce Dr. Guy Katz, who will be talking about something I think almost everyone has a major interest in, making a correct diagnosis of IgG4-related disease. As many of us know, it's not as easy sometimes as some people might think. So, Guy, please.
Thank you very much. It's such a pleasure to be able to speak about this with all of you. I know this is something that has been coming up a lot this weekend already, and it's for good reason. It's not an easy process to actually get to a diagnosis of IgG4-related disease in many cases. So I'm looking forward to discussing this and to hearing questions. So some of the things we'll talk about are to discuss the tools that we have available to make a diagnosis of IgG4-related disease. We'll spend a while talking about the challenges in differentiating IgG4-related disease from its many, many mimickers. We'll explore some of the strengths and the pitfalls of the 2019 ACR-EULAR classification criteria, something that has come up a few times in other talks already. And we'll apply these concepts to some cases and see kind of how we can get to a diagnosis in certain cases. So I want to step back for a second and think a little bit more philosophically about what is a diagnosis. How do we define a diagnosis? And I would argue that it's context dependent. So in some cases, there are very strict objective criteria that we can use that define a diagnosis. For example, in diabetes and blood pressure and cholesterol problems, there are very strict criteria, thresholds, beyond which if the blood pressure is above a certain number, research has shown over time that bad things can happen in the future. And we know that those people benefit from being on medications or other interventions to lower the blood pressure or lower the blood sugar, whatever it may be, to prevent those complications from happening in the future. So in those cases, it's something very strict and objective. In other cases, it's something that's defined by a specific clinical presentation, like a heart attack or a stroke. That's the diagnosis. And in other cases, it's something that can be defined based on a biopsy. So for example, most cancers are defined based on the presence of certain cancer cells or certain genetic mutations within those cells that are associated with the cancers. Unfortunately, those things don't really apply to IgG4-related disease as much as we'd like to think that they do. And there are a few reasons for that. For one thing, it's a very heterogeneous disease. And this, by the way, applies to all autoimmune diseases, and we have similar challenges in just about every other autoimmune disease. But these things are certainly true in IgG4-related disease. So it's very heterogeneous. The way that one patient presents is going to be different from how the patient next to them is going to present. We define it really based on clinical syndromes rather than the underlying pathophysiology. And that's very different from how we define some of the other diseases I mentioned in the previous slide. And that's partially because the underlying pathophysiology differs from patient to patient, as Dr. Perugino was describing yesterday, and because we don't have an easy blood test that we can say, exactly what everyone's immune system is doing. And related to that, we don't have any definitive diagnostic tests. And by that I mean a test that is always present in every patient with the disease and is always absent in patients who don't have the disease. There is no such test in IgG4-related disease. So the way we have to approach the diagnosis is really thinking about it more as a spectrum. And we think on the left side of the spectrum, we rule out the disease. On the right side of the spectrum, we confirm the diagnosis. And we don't have anything that can get us all the way 100% to the right side of the spectrum yet. Hopefully that'll happen in the future. But we have so many tools available to us that in many cases, or in most cases, we're able to get close enough to the right side that we feel very confident that we have the right diagnosis. So what are those tools? We think about people's symptoms, physical exam findings, laboratory findings, imaging findings. Biopsies are part of the diagnostic process in most people. And then we also have response to treatment as a diagnostic test. So let's talk a little bit more about all of these. Here are some of the most common symptoms that many of you in the room have probably experienced. So this is enlargement of the lacrimal gland on the left side and the submandibular glands in the middle. And these are classic manifestations of IgG4-related disease. But just to hammer home that this does not define the diagnosis, on the left side of the screen, you have two patients with IgG4-related disease. On the right side of the screen, this is a patient with sarcoidosis. a very different autoimmune disease, and it's also similarly affecting the lacrimal glands, the submandibular glands, and the parotid glands, something that we think of as very specific for IgG4-related disease. Imaging is extremely important. So much of the disease is internal, and very often the internal organs can be asymptomatic in many ways before they actually cause damage to the organs. So imaging is really important, and here you have on the left side of the screen, actually on both sides of the screen, examples of autoimmune pancreatitis, where on the left you can see that the pancreas, and let me see if I can find it there, the pancreas is right there and right there. In the top, you can see that there's diffuse enlargement of the pancreas, and it's kind of lost its normal contours. That happens because the pancreas is swollen and inflamed. And on the bottom left, there's a mass there, and many of you have experienced that mass lesions are something that we see commonly in the disease. But again, on the left side of the screen, we have type 1 autoimmune pancreatitis, which is IgG4-related disease. On the right side, we have very, very similar images, but this is a patient with type 2 autoimmune pancreatitis, which is not IgG4-related disease. So once again, imaging alone is not going to give us the answer. Here's another example of imaging. So these are 3 examples of retroperitoneal fibrosis. You can see where the arrows are pointing. There's inflammation surrounding the abdominal aorta and the iliac arteries, which are the large blood vessels within the abdomen. On the left, we have IgG4-related disease. On the right, we have Erdheim-Chester disease. And in the middle, we have angiosarcoma, which is a blood vessel cancer. So that's all just to say that imaging alone is not going to give us the answer in most cases. And like I mentioned before, symptoms and physical exam alone are not going to give us the answer. So what about serum IgG4 concentrations? There's been a lot of discussion about serum IgG4 concentrations already. Dr. Khosrowshahi shared this same paper in her talk yesterday, where this was the initial description that identified that patients with autoimmune pancreatitis have elevated serum IgG4 levels in many cases. And that was a really important discovery because it's part of what led to us recognizing that this is all one disease. But as was discussed yesterday, there are a lot of patients who don't have elevated serum IgG4 concentrations. Somewhere between 10 and 50% of patients don't have elevated serum IgG4 concentrations at any point in their disease. So we know that it's not a good enough test to identify everyone. But what about people who have really high serum IgG4 concentrations? How good of a diagnostic test is that? Well, that's been looked at. And this is a study that looked at patients who had serum IgG4 concentrations above 5 times the upper limit of normal, which we consider to be very high and is what gives someone the most points that they can get in the classification criteria from serum IgG4. And depending on how they defined IgG4-related disease, how well the serum IgG4 of over 5 times the upper limit of normal predicted the diagnosis of IgG4-related disease was around 70 or 75%. Which sounds pretty good, but if you think about it, that also means that about a quarter to a third of patients with extremely high serum IgG4 concentrations have a different diagnosis. So it's an important test for sure, and one that we get on every single patient who we suspect IgG4-related disease. But just like everything else we've talked about, we need to interpret it with caution, and we need to recognize that there's limitations to how we use the serum IgG4. There are other lab values, and the more abnormalities that we see that look like IgG4-related disease, the more convinced we get. So people can also have elevated serum IgG1, IgG3. IgE can be elevated and sometimes can be extremely elevated. The eosinophil count is often elevated. The complement components, C3 and C4, are very often low. And inflammatory markers, in particular the sedimentation rate, or ESR, very often elevated, whereas the other inflammatory marker we usually check, which is the CRP, is usually normal or only very mildly elevated. Moving on to histopathology, and when I say histopathology, I also mean biopsy. I mean if an organ is removed and the pathologist looks at it, so these are all referring to the same thing, and this is about the idea of looking at some tissue under the microscope and seeing what it looks like. This is an important part of the diagnostic process for almost everyone with IgG4-related disease, and is the closest we have to a gold standard for the diagnosis. The hallmark findings that we see in people with IgG4-related disease, Dr. Perugino and Dr. Khosrowshahi talked about these as well. We usually see a dense lymphoplasmacytic infiltrate, which is essentially just an immune infiltrate with very specific types of cells. And there's usually a high number of IgG4 positive cells and a high ratio of IgG4 positive cells compared to all of the IgG positive cells. We also see storiform fibrosis, which is scar tissue formation in this kind of typical woven pattern. And we see inflammation of the vein walls called phlebitis, which very often is severe enough that it leads to narrowing of the veins to the point where you can't actually see the inside of the vein. And that's called obliterative phlebitis. So here you can see in the top, there's what looks like just a dense immune infiltrate. There's a lot of kind of purple cells right where the arrow is pointing. But in a stain that's specifically looking for blood vessel walls, you can see that that whole area is actually a blood vessel that you can't see the inside of because there's so much inflammation there. So let's explore the idea of histopathology or biopsy being the gold standard for a diagnosis. I'd like to share this case of a patient who had pachymeningitis. That's inflammation surrounding the brain, inflammation of the lining around the brain. And this patient had a really severe course. He was in and out of the hospital a lot, requiring quite a lot of treatment. And he initially came with the diagnosis of IgG4-related disease. You can see in the top left, there's a dense lymphoplasmacytic infiltrate. These other stains are showing that it's the right cells, that it is lymphoplasmacytic. And here are the IgG and IgG4 stains. You can see that they're both quite positive, and there's a large number of IgG4 positive cells in the biopsy. So it looks really good for IgG4-related disease. But when the pathologists took a closer look, they were able to find areas where there are also other types of inflammation that we don't see in IgG4-related disease. So here we see what are called multinucleated giant cells and neutrophils. These are types of immune cells that we really don't see in IgG4-related disease. So this patient's diagnosis was not IgG4-related disease. It was something called granulomatosis with polyangiitis or ANCA-associated vasculitis, something that's probably come up on the list of possibilities for many of the people in the room because there's so much overlap between the two diseases. But you can imagine that initially those other features were not seen in the biopsy. And you can also imagine that if you take a really tiny piece of something that's inflamed from an entire organ, it's very possible that you miss the parts of the biopsy that show you the things that tell you that it's actually a different diagnosis. So we should be cautious even when we interpret biopsy results, recognizing that they're really helpful diagnostically, but still not perfect. So to expand on that a little bit more, if we think about histopathology as a gold standard, it really doesn't hold up as much as we'd like to think that it does. These classic findings of storiform fibrosis, obliterative phlebitis, dense IgG4 positive lymphoplasmacytic infiltrate can be seen in many, many other conditions, and there's a lot of literature on that. So we see it in IgG4-related disease, but it's not specific enough for the disease that we can definitively make the diagnosis based on that. And then some biopsies can be limited samples, or they can be affected because people are receiving treatment before they got the biopsy. If someone's been treated with a lot of prednisone or other treatments before they got the biopsy, it really affects what the pathologists are able to see under the microscope. And very importantly, a biopsy is not always possible. Depending on the part of the body that's involved, sometimes a biopsy can be very risky and may not be worth the potential benefit, especially if the suspicion for IgG4-related disease is already really high to begin with for other reasons. And moving on, the final diagnostic test that we have that's not a diagnostic test is response to treatment. And that's something that can be really helpful and that we use routinely in trying to figure out if we have the right diagnosis. When we suspect IgG4-related disease, we treat it usually with steroids, very often with B-cell depletion, medications like rituximab, and we expect to see a really good response to those. And when we don't, we question the diagnosis because there's just it's so universal that people have response to those. But this too, just like all of the other diagnostic tests, has some caveats. In particular, you need to make sure that it's the adequate dose and duration of treatment. You know, a 5-day course of prednisone is not going to be enough to get someone with IgG4-related disease throughout their whole body to be in remission. And it's also important to recognize that there are certain problems that the disease can cause that present more with damage rather than active disease. And what I mean by that is active disease is when there's an active immune infiltrate. You can see all of the dense lymphoplasmacytic infiltrate if you were to get a biopsy. There's a lot of immune cells causing inflammation. The treatments that we are using in the disease are targeted towards that inflammation. But over time, that inflammation can lead to a lot of scar tissue formation, and it can lead to organ dysfunction even outside of the presence of active disease. And when we treat with steroids or with rituximab or other medications targeted at the immune system, it doesn't do anything for those clinical problems. Those need to be managed separately. So if damage is not getting better with treatment, that doesn't mean it's the wrong diagnosis. It could be that just needs to be looked at separately. But despite that, response to these treatments can really be used as a diagnostic tool, and we use it routinely. So going back to this continuum, how do we actually approach the diagnosis? Is we take all of the pieces of information that we have available to us, all of the symptoms, the physical exam findings, the lab evaluations, imaging, biopsy results, and response to treatment. And that tells us whether we are moving more towards the left side of the continuum or the right side of the continuum. And usually by incorporating all of these things, we can get close enough to the right side that we feel really confident in the diagnosis. Putting that into slightly more concrete terms, the way we approach the diagnosis is first, we need to recognize the typical clinical manifestations or biopsy findings, histopathologic findings of IgG4-related disease in one of the typical organs that are involved. We do a laboratory evaluation. We look at things like the serum IgG4, the complements, the eosinophils, all of those other things that I mentioned before. We evaluate for evidence of other disease, even in people who don't have many symptoms to suggest other sites of involvement. We usually do cross-sectional imaging like a CT scan or an MRI to look for other places that could be involved, because that also gives us a clue for the diagnosis and tells us what we need to be treating. And very importantly, we exclude the relevant mimickers. Now, this sounds like a lot, and it is, but at the same time, we also have a really helpful framework that was developed, and that's the classification criteria that were developed and published in 2019, 2020. And this is really one of the biggest advancements that the field of IgG4-related disease has been able to enjoy since 2011 when the first symposium happened. So this, I think, is one of the most helpful tools for people to arrive at a diagnosis, but this too has limitations. So let's go through it a little bit more. So the first step of the classification criteria is what's called entry criteria, which is that there needs to be clinical or radiologic or histopathologic evidence of inflammation in one of the typical organs that we see in IgG4-related disease. And we've talked about what some of those areas are: the orbits, the salivary glands, the pancreas, the retroperitoneum, etc. The second step, which is probably the most helpful step to clinicians out of the classification criteria, is the exclusion criteria. These are manifestations that patients can come with. They can be clinical manifestations, it can be laboratory abnormalities, it can be imaging findings, pathological findings, all that are very atypical of IgG4-related disease and really suggest a different diagnosis. This is extremely important because it really helps identify what are the features of the presentation that aren't consistent and might suggest that there's something else going on. If someone doesn't have any exclusion criteria, then they move on in the classification criteria to step 3, which is inclusion criteria. And that's where they get a certain number of points for the different things that the patient has, and they get more points the more specific that thing is for IgG4-related disease. So they get a certain number of points for different biopsy finding results, and they get different points for how high the serum IgG4 is. I mentioned the most points is if the serum IgG4 is over 5 times the upper limit of normal. And then there are points that are given for different clinical manifestations. How many glands are involved? What do the kidneys look like on imaging? Is there retroperitoneal fibrosis? Things like this that really help guide us or clue us into the diagnosis of IgG4-related disease. And the more someone has, the more points they get. And they defined the number of points that are needed to classify the diagnosis as 20. So if someone has 20 or more points, then they are classified as having IgG4-related disease. So that sounds really great, and I think is something that could have led to the diagnosis in many of your cases. But let's talk about some of the challenges with this. It was intentional that these were called classification criteria and not diagnostic criteria. There is a difference between the two. The purpose of classification criteria is to identify a homogeneous population of patients who almost certainly have the same disease, and it's really for research purposes. But we started all of this by talking about how this is a heterogeneous disease. So we are artificially turning a heterogeneous population into a less heterogeneous population. By necessity, the classification criteria really emphasize minimizing the false positives. They want to make sure that anyone who fulfills the classification criteria definitely has the disease to the best that we can predict it. But this comes at the cost of false negatives, meaning some people can have the disease, but not fulfill the classification criteria. Now, the good news about it is almost, not quite everyone, but almost everyone who fulfills classification criteria probably does have the disease. So let's actually apply that to a few cases. Here's the first case, and these are all inspired by cases that I've seen with slight tweaks. So this is a 55-year-old man who has enlargement of the lacrimal, parotid, submandibular, and sublingual glands, thickening of the airways within the lungs, it's called bronchial wall thickening, inflammation around the coronary arteries, the arteries that feed blood to the heart, inflammation around the abdominal aorta and surrounding soft tissues, retroperitoneal fibrosis, dark areas within the periphery of the kidneys on CT scan, which is something that we know is associated with inflammation of the kidneys and IgG4-related disease. Serum IgG4 is nearly 15 times the upper limit of normal. The ESR and the IgE are elevated, and there's no other unexpected findings that have come up as we've evaluated the patient. So let's apply the classification criteria to this patient. Here are the number of points that he gets for the different manifestations. Note that not everything gives him points. There are things on here that are very consistent with IgG4-related disease that he gets no points for. Keep that in mind when we think about how we apply the classification criteria to people who don't have the most typical presentations. If you sum up those points, 43. So certainly fulfills classification criteria, and that's without a biopsy even being performed. Now, this patient eventually did have a biopsy, and it did confirm it looked very much consistent with IgG4-related disease. But this is a case where the clinical diagnosis seemed fairly clearly IgG4-related disease. The classification criteria clearly agreed. Here's another case. A 35-year-old woman has diffuse pancreatic enlargement and peripancreatic inflammatory changes. It looks like autoimmune pancreatitis. She also has irregularity of the bile ducts fairly diffusely, both within the liver and between the liver and the pancreas. These are the ducts that bring bile from the liver and excrete it into the intestines. And she has inflammation of the colon that's seen on a colonoscopy. There's no other sites of involvement, and her serum IgG4 is elevated. It's between 1 and 2 times the upper limit of normal. So let's apply the classification criteria. When there's the combination of pancreatic and biliary involvement, that alone leads to 19 points because it's something that's so specific to IgG4-related disease that alone almost gives someone the ability to be classified as IgG4-related disease. Add to that a mildly elevated serum IgG4 concentration, another 4 points, and we've got 23 points. So this patient would be classified as IgG4-related disease. But there's a very important exclusion criterion, which is inflammatory bowel disease is an exclusion criterion for patients who have exclusively pancreatobiliary disease. So this patient wouldn't even get to go through the process of getting the points in the classification criteria because the likelihood of IgG4-related disease goes down significantly since inflammatory bowel disease is also associated with autoimmune pancreatitis and the irregularity of those bile ducts and something called primary sclerosing cholangitis. So in this case, it's most likely that the patient actually has type 2 autoimmune pancreatitis rather than IgG4-related disease, and that's why the classification criteria would exclude the classification of IgG4-related disease. So this is another example of where the diagnosis and the classification criteria seem to agree. The most likely diagnosis is probably not IgG4-related disease, and the classification criteria also agree with that. Does that mean IgG4-related disease is impossible? No, It's certainly possible that someone could have the unfortunate combination of those two things, but it's far, far less likely, and it's much more likely that it's all driven by inflammatory bowel disease. Case 3 is a 40-year-old woman who's presenting with diffuse enlargement of the thyroid to the point that it's causing difficulty with swallowing and difficulty with breathing. And a biopsy is done that shows a dense lymphoplasmacytic infiltrate with obliterative phlebitis. The IgG4 to IgG ratio is 50%, and there's a lot of IgG4 positive cells per high-powered field. This is a biopsy that's very, very consistent with IgG4-related disease. I think everyone in the room could agree on that. There are no other sites of involvement, no lab abnormalities, normal serum IgG4. So let's apply the classification criteria to this patient. She has inflammation in a typical organ. The thyroid is an organ that is typically that is considered to be a typical organ in IgG4-related disease, and the biopsy is quite consistent. But the number of points that she gets is really only from the biopsy, and that biopsy gets her to 19 points. So she comes close, but she does not fulfill classification criteria for IgG4-related disease. But her diagnosis is IgG4-related disease. There's really no doubt about that. So this is just one of the limitations of using classification criteria and why they shouldn't be taken as kind of the gold standard for the diagnosis. And our final example is a 70-year-old man with soft tissue inflammation surrounding the abdominal aorta and the iliac arteries, a pretty typical presentation of retroperitoneal fibrosis. Also has inflammation of the orbital muscles, so the muscles behind the eye that control eye movement, something that we see very commonly in IgG4-related disease. The serum IgG4 concentration is over 5 times the upper limit of normal, but a biopsy of both of these sites is felt to be very high risk. A biopsy of an orbital muscle can lead to double vision, that can be permanent, and a biopsy of retroperitoneal fibrosis is very often not safe because it's so close to the aorta and can lead to severe complications there. So a biopsy is not done. Well, let's apply the classification criteria here. We get 8 points for the retroperitoneal fibrosis, 11 points for the extremely high serum IgG4 concentration, and again, the patient has 19 points. Does not fulfill classification criteria for IgG4-related disease. What is the patient's diagnosis? It's almost certainly IgG4-related disease, right? There are other diseases that can look kind of similar to this, but far and away the most likely here is IgG4-related disease. We just can't get to the point where the classification criteria agree with that because we can't get a biopsy. So in summary, there's really no one disease feature or diagnostic test that can definitively establish a diagnosis of IgG4-related disease, but we do have a lot of tools that can get us there. Diagnosing the disease really involves a comprehensive review of the clinical presentation, the labs, imaging, and biopsy findings. And equally important is recognizing all of the mimickers of IgG4-related disease and prioritizing excluding those to the best of our ability, depending on how each patient is presenting. The classification criteria that were developed are an extremely helpful guide for how to identify the right patients, how to evaluate a patient, and how to increase or decrease your level of suspicion for IgG4-related disease, but they really can't be used as a substitute for clinical judgment, and they can't be used as a definitive diagnostic test. And very importantly, as was discussed multiple times yesterday, we need more reliable diagnostic markers. It would be lovely if we could have a test that is always positive in every patient with IgG4-related disease and always negative in every patient without it. At least in 2024, we don't have that. Thank you very much for your time and attention, and I'm happy to answer questions.
Terrific talk, as always, Guy. So remember, we have 2 banks of microphones, and we have 1 questioner here. So please start, Lisa.
Yeah, that's such an important question, and one that we encounter all the time with many patients, and is always a challenging conversation. So I approach that in a few ways. One is there are certain types of mast lesions that are more common in IgG4-related disease than others. 2 is we always need to have a low threshold for getting a biopsy to make sure that we're not missing a cancer. It's better to get a biopsy and to find out that it's still IgG4-related disease rather than to skip the biopsy and allow a potential cancer to go on. But another thing that we often do is if it looks like the disease is active and there's a new mass lesion that's developed somewhere, whether it's the pancreas or the lungs or where it may be, something that we can do is treat the disease and repeat the imaging after a very short time frame. And that's something that we do frequently for pancreatic masses in particular, when it's not 100% clear whether it's a cancer or whether it's the IgG4-related disease. We'll treat it, and we expect the size of the mass to go down fairly substantially in a fairly short time frame. And if that doesn't happen, then we need to really pursue the possibility of a cancer diagnosis even more. I hope that answers the question.
Ms.
Hi.
Piazza.
Thank you very much. My question is, are all fibrous lesions created from IgG4, or could they be created from other autoimmune diseases? And when you do these histopathic overall look at a patient, are you looking at that one particular flare-up or an accumulation of many times within a short period of time, them a criteria number?
I see. Yeah. So I'll start with your second question of when we're applying, if I understand correctly, when we're applying the classification criteria, are we looking along the patient's entire clinical course or at one snapshot in time? We're applying it to the entire clinical course. So if they had salivary gland disease 5 years ago and they have pancreatic disease today, but their salivary glands are normal now, we would still count both of those.
Okay.
And I think that's how we approach the diagnosis as well, because people don't have to have all of the disease manifestations at the same time. If they're there, then they're there.
Okay.
As for your other question about fibrosis or scar tissue formation, yes, we can certainly see that in other diseases, both autoimmune diseases and non-autoimmune diseases. There are a lot of different reasons that scar tissue formation can occur, either part of a healing process from an injury, or it can be a primary immunologic problem. So there's a lot of different reasons for it. IgG4-related disease is one of a few, it's not the only, it's one of a few autoimmune diseases that just tends to cause a lot of scar tissue formation.
So if I may, just to follow up to understand, if you do get a lesion from any one of the autoimmunes or IgG4, once it's happened and it becomes fibrous, does it come back, or could it come back in the same spot, or does it travel somewhere else?
Either one can happen, yeah. So once it happens, there can be a certain amount of scar tissue formation that happens within that organ, and very often that's something that the patient never feels. It's something that we're able to see if we were to biopsy it, or on imaging we can see evidence of that, but it doesn't cause any symptoms in many cases. In other cases, it does cause symptoms. But that organ can become involved again in the future. So when the disease relapses, it could be that, if we're talking about the salivary glands can enlarge again, even though they were fibrous before, or new sites of involvement can happen. So either one or both can happen.
All right, thank you.
Yeah.
So we'd love to get all three remaining questions in, so maybe quick questions and quick answers if possible. Bert.
Question about number 4, your example number 4. Would you use treatment with steroids as a further means of deciding whether it is IgG4-RD? And more in general, when you use treatment to decide whether or not it is IgG4, how quickly would you expect to see the results of the days? Is it weeks?
Yeah, so that's a really important question as well. So how fast we see a response is very patient dependent and organ dependent. Some manifestations melt away within days. Some take weeks to really be able to see a substantial improvement. So that's very context dependent. And when we use prednisone in particular as a diagnostic test, we always have to keep in mind that prednisone treats a lot of different diseases. Virtually everything gets better with prednisone. So I think about it more the other way around, where if it doesn't get better with prednisone, then I question the diagnosis. But a response to prednisone does not necessarily mean that it's IgG4-related disease. It could still be others.
Okay,
Yeah.
thank you. Hani, did you have a question?
It's not a question, but just thinking by a loud voice. Instead of searching a new marker for diagnosis, regarding the difficulty of taking a biopsy in certain cases and the lack of definitive laboratory test or radiological test or radiological examination, is it beneficial or does it justify to develop a new diagnostic criteria in a score representing the clinical manifestations, laboratory tests, radiological studies, and the biopsy, and the total or the sum of the score will make the diagnosis or the decision of diagnosis, like the classification criteria, but this will focus on the diagnosis. And this question, if it is a question,
Yeah.
is directed to Dr. Stone.
Oh,
No,
no.
it's-
That's
it's-
Dr. Katz is going to handle that one.
It's a great point, and I think that you correctly identified that is how many people are using the classification criteria, but that's not what the classification criteria should be used as. The challenge with developing diagnostic criteria is it is such a heterogeneous disease, and the tests that we have for it aren't specific enough that if we were to do that, we wouldn't have, right now, in 2024, we wouldn't have the ability to be so confident that anyone who fulfills the diagnostic criteria truly has the diagnosis. And what we'd probably be dealing with would be a lot of false positives. We don't have, right now, the tools at our disposal to be able to perfectly, with 100% accuracy, say this is IgG4-related disease and this is not. And that's the reason I think we don't have diagnostic criteria. So right now we're still, and this is the way we approach almost all autoimmune diseases. We rely on clinical judgment and incorporating all of the data that we have available to come to the best idea of the diagnosis.
Thank you.
Yeah.
It's a great question, and I would add that this is something that the physicians in the room are comfortable with, because so many of our IgG4-related disease is not the only disease that is so complicated. It's pretty typical of autoimmune diseases, and I think the American College of Rheumatology and the European League Against Rheumatism have issued the idea, and I think it's correct, that you can't really have diagnostic criteria if you don't know what the cause of the disease is. We know what the cause of Lyme disease is. It's caused by a tick bite and infection with Borrelia burgdorferi. We know what the cause of gout is. It's caused by excessive uric acid depositing in joints. So it's possible to have diagnostic criteria for those diseases. We don't know what causes IgG4-related disease yet. So until we do, we really can't have diagnostic criteria. We have to live with these classification criteria.
Agreed.
Okay, Guy, thank you very much.